Thank you very much, Mike, Ambassador Nkongasong, Ambassador Gooseby, Dr. Gandhi. Thank you for that panel discussion. You've just heard a broad conversation about the future of global health and what it might look like. And the question we've been asked multiple times is, why does global health matter to UCSF, and what can UCSF contribute? So we have a short video that shows why UCSF has the tagline of advancing health worldwide. Thank you. The Institute for Global Health Sciences grew from the simple idea that advances in science and in health should be accessible to people no matter where they live, whether that's in rural United States or it's in a low middle income country on the African continent. It's the framework of health equity. And throughout the past 25 years, the Institute for Global Health Sciences has been the engine that tries to drive that forward.
Science sees no boundaries. Human health sees no boundaries.
No matter what school or field you're in, we're all focused on the same thing, to go ahead and help the world live better.
Our mission statement is advancing health worldwide, and our global health science program, started by Haile Debas, one of my absolute heroes, preceded that mission statement, and I think inspired that mission statement. He understood that we were a powerhouse in medical discovery and in clinical care, and he really challenged us to think big.
When Haile started talking about his vision for global health, I think that then allowed us to see that we had not only an obligation to care for our communities here in the Bay Area and California, but we had a greater obligation to care for the world.
Global health is critical in the way the world will have to respond if we have a pandemic. Every university has the obligation to do global health.
The HIV pandemic here in the early 80s was a galvanizing event for UCSF. It became a pandemic that created a generation of leaders who understood the key role of science in overcoming public health problems.
The HIV epidemic, we were ground zero in San Francisco. And Ward 86, the inpatient unit 5A, which was started by a bunch of nurses who brought together a unit to provide HIV-focused care. And when this whole thing sort of exploded globally, naturally, the people who were working in that field, of course, wanted to share their expertise.
The HIV crisis was the moment where UCSF led by partnering research, clinical care, and community partnerships. And that combination is the best way to intervene on a health crisis. Same thing happened during the pandemic. So that framework is very much embedded in our DNA. It's an interdisciplinary exploration that brings research, education, clinical care, and community together to deliver the advances that come through, discovery.
The words Institute of Global Health Sciences were very carefully selected because it was harnessing the scientific machine of UCSF to bring discoveries into the field of global health. How can we diagnose diseases like malaria using incredibly modern, hard-hitting tools?
We're working in more than 80 countries across a multitude of disease domains. It's a linkage of discovery through to delivery with implementation. And that is, I think, what's driving the reputation of UCSF.
Global health sciences cuts across all the schools and is identifiably important to the top leadership of the university.
You have a cabinet-level institute where people are really excited to collaborate across schools in order to look at issues that are related to worldwide health.
One of the most valuable things about global health sciences is that they already have the framework to make an impact worldwide. So whatever the health problem we want to focus on, they can use their network globally to help us answer those questions.
Pharmacy is a global profession, and so my faculty are very concerned with developing drugs that are accessible to everyone. And by having such an institute, it connects us to world populations, to research, to teaching opportunities, and to really supporting the role of our healthcare professionals in global activities.
One of the aspects about global health is that it is an interconnected ecosystem. There's no way we can develop some of the vaccines we need for some of the most deadly pathogens in the world without being connected internationally.
And at UCSF, we've emphasized that our job is not just here at the university, but to actually make our advances known to everybody throughout the world. And we have emphasized collaboration.
What I've been most proud about of the Institute is its ability to move with the times to much, much more of a partnership model where we're learning from each other to build capacity in country. And if we can achieve that for the next 25 years, I'll be super happy.
Haile set a very clear vision that is still enduring. And it was that UCSF's excellence in clinical care, in science, in education, training, mentorship, must be applied to health equity. That vision has been the vision that has led us all along the last 25 years and will continue to do so for the next 25 years. And I'm very excited about its future.
Good morning. My name is Paul Wesson. I am the Associate Director for Science here at IGHS. To continue the theme of unity in global health across UCSF, we are delighted to feature a series of lightning talks on innovative global health research taking place across the university. Now, as much as we all live for cutting-edge, paradigm-shifting science, if we were to showcase all the amazing global health research on campus, we might be able to let you out by Thanksgiving. And that's being ambitious. So instead, we asked the deans of each of the schools to nominate one early-stage investigator whose research is illustrative of the innovative science underway in that school. And I'd like to invite all the early-stage investigators up now, please. So as with the last session, we have a QR code for any audience questions, and we will begin with our first speaker, who is Dr. Calvin Chu, who is an assistant professor in the Institute of Health and Aging. He was nominated by Dean Carol Dawson-Rose from the School of Nursing, and he will be speaking on building public-private partnerships to increase access to healthcare services. Dr. Chu?
Great, thanks Paul for the introduction. So today I'll give a quick snapshot of my research agenda around building public-private partnerships to increase access to healthcare services. How do I do the slides?
Stand up here.
Sure, thank you. Okay, so I think there's a huge potential of pharmacies and drug shops to increase access to public health care services for vulnerable populations. So first of all, just as an empirical fact, these drug shops and pharmacies are often the first point of contact for care seeking, and because they're conveniently located. And it has the possibility to increase reach among vulnerable populations who wouldn't access care and services from traditional public health facilities otherwise. And in doing so, if part of the load can be shared by the private sector, we can decongest public healthcare systems and make healthcare better for both people accessing private and public care. And I think this is especially important in the current funding context with limited funding and uncertainty in that we can leverage cost sharing among users. So I want to highlight this research agenda through 3 different case studies of a series of projects I've been working on across East and Southern Africa. So the first is a series of studies on drug shops and pharmacies on HIV self-testing and sexual and reproductive health in Tanzania. So several years ago, in collaboration with Jenny Liu and Sandy McCoy and others, we developed a youth-friendly Malkia Klabu loyalty program. So the idea here was that using human-centered design, we were able to get drug shops to distribute HIV self-test kits and other contraceptive products to adolescent girls and young women for free, and then get reimbursed for them by the study. So the idea was this essentially provides a pathway for sustainable public-private partnerships with future room for reimbursement. But in the process of this, we also discovered that drug shops had inherent pro-social motivation. So specifically, we saw that qualitatively, drug shops and pharmacies and pharmacists were seeing their role as a health provider. So they're trying to do good to adolescent girls as well, specifically in the form of providing discounts to products and vulnerable populations, and exploiting the fact that these drug shops are willing to provide differential discounts to different consumer segments. We developed a series of studies to try to leverage that to increase access to care. So first, we developed these non-financial incentives using the behavioral economics literature to try to leverage the fact that we can use summary reports and customer feedback from these adolescent girls to encourage shopkeepers to keep doing the good work that they're doing and leverage this pro-social motivation. And this led to a 60% increase in sales to young women customers in our pilot. And as part of this series of projects, we're currently working on an R01 of trying to use procurement subsidies to encourage drug shops to provide HIV self-test kits to adolescent girls for free and simultaneously sell to the general population in order to balance the sort of profit-making motivations as well as their pro-social motivations as a health provider. Secondly, we have a series of studies in Rwanda in collaboration with Good Life Access, a private pharmacy chain. And this is focused on NCDs and new technological breakthroughs around cervical cancer. So Good Life Access has developed this pretty expansive screening program of NCD screening around obesity, hypertension, and diabetes, where they managed to reach over 10,000 people for these NCD screenings at pharmacies because it's much easier to access care at these pharmacies than the public health sector. So what we're trying to do here is to explore the feasibility of integrating this new technology of cervical cancer screening with self-swabs into pharmacies so that other populations are able to access cervical cancer self-swab care through pharmacies and not just the public health system. And this work is funded by the IGHS RAP, and I think we're pushing on the frontier here where we're combining advances and breakthroughs in biomedical technologies like the self-swab and making sure that from an implementation science perspective, this is able to be disseminated through pharmacies in actual real-life settings. And the benefit of this project is that we can eventually figure out what the sustainable long-term goal is, in that we can establish public-private partnerships where the government reimburses NCD screening at pharmacies through national health insurance. And then the third series of studies we've been developing is working with drug shops or PPMVs in Nigeria to tackle the problem of malaria test negatives. So this has been a very tricky problem for multiple decades in that you have these profit motives where if someone tests negative through a rapid diagnostic test, then you have these drug shops who are still trying to sell them ACTs regardless because they're making money. And it's very tricky to sort of force these PPMVs and drug shops to not oversell and not push people to purchase treatment due to the profit incentive. So because of that, we're trying to work with Lagos State and the pharmacy software provider MyShaMeds to explore the readiness of PPMVs to provide treatment for malaria test negatives. So instead of trying to sort of regulate our way and force people not to force sell treatment, what we're trying to do is to provide them with alternative treatments. So if hypothetically we can get these drug shops to provide adequate and proper treatment for the malaria test negatives and make money off of it as well, then we can sort of reverse the economic incentives and make sure that drug shops are both serving the public health good as well as making money to sustain their businesses. So this series of projects demonstrates the potential of private-public partnerships to tackle long-standing problems of access to healthcare services across multiple disease areas. And I think this is just a very brief snapshot of the type of work that myself and my collaborators do. So I would like to acknowledge my collaborators at IGHS and UCSF more generally, including Jenny Liu, Laila Sheira, Al Abdulatif, and George Sawaya, as well as our global partners at Health for a Prosperous Nation, Maisha Meds, and Good Life Access. So please feel free to reach out to me for additional questions, and we can explore additional collaboration opportunities going forward. Thank you.
Thank you, Dr. Chu. Our next speaker is Dr. Amelia Deichmann, who is an associate professor of clinical pharmacy. She was nominated by Dean Kathy Giacomini from the School of Pharmacy, and she'll be speaking on HIV cure research.
Thank you so much. I'm going to stand because I got to move around. So I'm going to be talking about HIV cure research today and just a very high-level view. So I think now more than ever, we need to be pushing for cure, especially with the drawback of resources towards access to ARD and implementation. This is only going to bring us so far. And I think we need to be pushing really on all fronts. And I think a theme that's already been echoed today is really that research, needs to be for everyone, and we need to be focusing on a cure for everyone. And this includes both access, but also biological differences, so sex, subtype, and also thinking about concomitant medications and things like that. So we really need to think very broadly, and this is where the global health piece really comes in. And then really UCSF has been leading the way through groundbreaking mechanistic trials, and I think this sets the stage for a lot of things that are happening globally that I'll talk about in a few moments. So my team was really formed out of the drug research unit, which was started by Fran Uika, or it was led by Fran Uika prior to my co-directorship with Lusheng Wang. And we have been engaging over the last 5 years, 5 or 6 years in HIV cure research with the existing infrastructure here at Pride Hall and at the General Hospital with the great clinical team. I don't know if this is a pointer, but with Steve Deeks and Michael Peluso that lead that team, and then as well as amazing group of study participants and the prospective cohorts that they have there, as well as the amazing work of immunologists and virologists, many of whom are in this room today. And so I'm just going to be highlighting the results of a trial that's going to actually be published in Nature on December 1st, which is World AIDS Day. And this is the UCSF AMVAR combination cure trial. And Michael and Steve really worked with a huge number of stakeholders. And I think that's one thing that I hope you take away from this presentation is that this is such a group effort of engaging community members and stakeholders, and not just NIH or academia alone. And we as pharmacologists, myself and Hari Tumala, worked with the immunologist Rachel Rudeshauser, who really led the scientific immunology work, and her PhD student, who's now a postdoc, Demi Sendel. And this trial was a combination cure trial of a therapeutic vaccine as well as a latency reversing agent to reactivate virus, and then dual broadly neutralizing antibodies that target HIV and potentially induce a potent immune response, which we are still trying to understand. And during the final stage of the trial, during the final stage of the trial, we had people come off of antiretroviral therapy, and then we monitored their plasma viral loads as well as many other immune markers. And at the same time this trial was going on, there was a prospective parallel study funded by the Gates Foundation that was going on here at UCSF in this cohort that was just doing an observational treatment interruption study. And so from that study, I'm sorry, I'm not very good with the pointer here, we saw that people who were known prior non-controllers had a certain rate of viral rebound, and then people who were, this isn't working very well, who were known prior controllers, who tend to have some control of HIV on their own off of ART, had a lower rate of rebound. But then when you compare that to the results of the AMFAR participants, we had some people who were really not controlling post the intervention once they came off of ART, who had similar to prior controllers, so there may have been some impact of the other interventions that wasn't totally clear. And then in the group, in the 6 people that rebounded that had, but that had some form of control, those people had a dramatically decreased slope in their rebound. And this is one of the most promising cure studies to date, I think. And these are the viral rebound curves of all of the participants of the study. So there was 10 participants. 3, we would say, had more typical rebound curves. 1 stayed off of ART for over 18 months and did not rebound at all. And then we have these 6 individuals who had some form of modulated viral rebound and decreased viral set point, so indicating some form of post-intervention control. And when we did our pharmacological analysis, we found that the exposure of the broadly neutralizing antibodies, which was that last antiviral therapy that was given, was related to the time of this rebound, but it was not related to this post-intervention control that was observed. And that lack of association you can see here with the 2 broadly neutralizing antibodies. But the immunologists were then able to go ahead and take this and look at a wide array of immunological measures, and one of the key findings was that there was for people who had lower set points, so better viral control, they tended to have higher Ki-67, so in their naive CD8 T cells. And this is the kind of this population of anti-HIV T cells that is able to kind of pounce on rebounding virus. And so it seems like they had some better form of control. And so really this trial is part of an ecosystem of innovation that's not just here at UCSF, but it really is going on globally. But it was one of the first trials that really is showing some form of control with these broadly neutralizing antibodies in combination therapy. And I'm just highlighting a few of the most recent studies that are either completed or ongoing. One is the FRESH cohort, which is taking place, which was completed in Durban, that was presented this year. One that's ongoing is the Acacia study, and there are many others within the AIDS clinical trials group. Again, many different stakeholders, many different supporters. And then there's a broadly neutralizing antibody study of Rio that's taking place in the UK. And so I think the next 25 years is what they asked me to comment on. Is I think we're really going to focus on a thorough understanding of effective pharmacological mechanisms of cure. And I think the promise of novel modalities like gene therapy and cell-based therapies, but many others, and just our sheer relentlessness of what we do here at UCSF, I think is going to really pave our way in the next 25 years. And I think that's been something that I just appreciate so much, is just to not give up. And I love this quote. It's been my lifeline this year, is someone sitting in the shade today because somebody planted a tree a long time ago. And I think hopefully the rain is watering that tree today. But thank you.
Thank you, Dr. Dietschmann. Our next speaker is Dr. Devin Jagannath, who is an associate professor of pediatrics. He was nominated by Dean Talmadge King from the School of Medicine, and he will be speaking on novel diagnostics for pediatric tuberculosis.
Thank you so much, and yeah, this is a real honor to be here at this wonderful celebration and to be able to share some of our work on advancing pediatric TB diagnostics. So, what's my motivation? Currently, every year, 1.25 million children are contracting TB disease, and of them, 200,000 are dying. That's about one child dying every 3 minutes. But why is that? This is a curable disease. I can say that again. This is a curable disease. If treated, they will do well. So what's the issue? We're just simply not finding them. If we look at children who are we think have TB, about half of them are not being reported to public health systems. And children under 5, that's 2/3 of them that are not coming into care. Because we just do not have the right diagnostics to give them access and get them into treatment as soon as possible. So when I think about my motivation, I think about the children that we care for, including here in San Francisco. And it's just simply unacceptable that we don't have a simple point-of-care diagnostic that can get children treatment as soon as they can be diagnosed. So my work is really centered on building a network of change, and that includes really amazing partnerships with around the world and here at UCSF and in the nation to really build networks for diagnostic evaluation and biomarker discovery for children. And that includes a variety of networks, as I outlined here, R2D2 Kids, supported by the NIH, State Department as part of our Smart for TB consortium, biomarker-based studies, including COMBO and PROTECT, and then work that I do, as I'll mention, on digital diagnostics and lung sound analysis. And what's really amazing is that this work is really being done in parallel to the adult studies, because we really can't rely anymore on this delay in which we first are doing work in adults and then moving to children. So we're really doing this in parallel in order to reduce, again, this inequity. So I'm happy to share some of the progress that we've made and have 3 stories today. Firstly, one of the big challenges for childhood TB is really that this current standard, which is sputum-based testing, is either not feasible to obtain or in community-based settings, they may not have access to it. And so how can we develop and move forward near point-of-care molecular testing? And so as part of the R2D2 Kids study and ADAPT for Kids study, we've really been working to advance swab-based molecular testing. And excitingly, we're really seeing promising results. Firstly, this is one platform, very small, easy to implement with a battery near the point of care. And as you can see in this table, sputum-based testing, thankfully, works as you'd expect with other more complicated molecular platforms. But as you can see the next row, we can get a large proportion of children just with a tongue swab that have microbiologically confirmed TB with high specificity. So this is really a game changer, and this actually is under review by the WHO currently, and so we'll see if this might be a reality in the next year, that we might have swab-based testing that could be for all individuals to increase access to care. The next story is, how can we move beyond respiratory specimens? For children, it's hard to obtain, and also, how do we think about screening on a larger population with non-sputum-based tests? And so as part of our biomarker work in COMBO, we partnered with the Gladstone Institute just across the street to, as well as with our global partners, to look at over 500 children in 5 countries to look for novel blood-based protein markers to be able to diagnose TB. And amazingly, we were able to identify some. We really were able to see, as you can see in this middle box, 3 to 6 protein signatures that could achieve the WHO target product accuracy for a TB screening test. And you can see that with that dot there in our different panels. And so the next steps are really, how can we move that forward? How can we develop a simple point-of-care test in order to enable better screening and access to care? Well, that all sounds great, but again, that would require maybe a blood sample, and maybe how can we think about what is truly a point-of-care, non-invasive test? And I think advances in AI and digital diagnostics really could leapfrog to this next step, where we really could think about ways to bring children into care faster. And so a lot of my work is focused on digital diagnostics, and in particular sound-based tools, whether it's cough sounds or lung sounds, and how can we take that rich information and really translate that again to a point-of-care test. And so in this example, we're collecting lung sounds. We've collected them in almost 1,500 children over the last several years, and we're building AI-based models. Again, this is in partnership at UCSF and also as part of the UCSF, UC Berkeley Computational Precision Health Initiative, in which we're building models to improve screening, where you can imagine a world where you have either a mobile phone app or a digital stethoscope, and you can automatically predict children that have TB or other lung disease in order to get them into care sooner. And in order to achieve this, this really requires a multidisciplinary global partnership, which I've been privileged to be part of, both locally and globally, in which we're working with basic and translational researchers to do this discovery work, understand better about the mechanisms of childhood TB, then moving to working with developers to evaluate their tools and continue to improve on it for children. And then how do we actually bring this into scale, and how do we actually think about implementation science and best ways to integrate that into normal care? And then critically, working with national and global public health agencies in order to really bring this into policy and care guideline. So just looking forward to the next 25 years, I really do think we have the ability to ensure that no child dies from TB, again, this curable disease. But that really requires a large committed effort to advocate for equitable access and resources for our most vulnerable populations. And so if this excites you, you have more questions, please, I invite you to join us as part of the UCSF Maternal and Childhood TB Initiative, which is part of the Center for TB at IGHS. And you can click on this QR code if you're interested to learn more. So with that, thank you for your time.
Thank you, Dr. Jagannath. Our final speaker is Dr. Nisarg Patel, who is an assistant professor of oral and maxillofacial surgery. He's nominated by Dean Michael Reddy from the School of Dentistry, and he'll be speaking on regulating and deploying AI in healthcare.
Thank you for the opportunity to take part in this wonderful celebration, and I'm excited to share some of our work looking at evaluating AI across the globe. First, consider a 52-year-old woman living in Oakland who's getting screened for diabetic retinopathy. Her doctor is using an AI device to help evaluate her eyes. The algorithm says she's fine, but what you don't know is that behind the scenes, the algorithm's performance decreased by 30% when evaluating African-American patients. Imagine her twin sister who lives in Munich. She goes to another doctor to get tested for diabetic retinopathy. The algorithm catches retinopathy because the EU mandates bias assessment, strict monitoring requirements, and comprehensive clinical testing before these products are launched. Two sisters, two wealthy nations, two drastically different outcomes. This isn't hypothetical. In the US, as of the last month, the FDA had cleared over 1,200 medical devices that implement AI algorithms. Only 2% of them underwent prospective clinical testing. 99% of them lack socioeconomic data, and about 80% don't even report patient ages in their clinical studies when conducted. Meanwhile, the EU's Comprehensive AI Act that was released last year mandates bias monitoring and demands representative data sets. And China represents full algorithmic transparency and traceability. We're witnessing a regulatory fragmentation that threatens to turn your zip code or your passport into a determinant of your quality of care and of AI safety. Our systematic analysis of global AI device regulations reveals 4 fundamentally incompatible approaches, and none of them work well enough. The US prioritizes speed. The FDA, like I said, has launched over 1,200 devices over the last decade, from 6 in 2015 to 1,200 today. They've created innovative mechanisms like predetermined change control plans to allow these devices to update in real time and provide limited reports to the FDA as opposed to applying for approval once again. But here's the problem. 97% are cleared through the 510(k) pathway, which means that they don't need prospective clinical testing. They need substantial equivalence to any device that's currently on the market. Only 3.6 of these products report race or ethnicity data. We're essentially mass deploying these devices with less evidence that we require for a new blood pressure medication. Europe has gone in the opposite direction. The 2024 AI Act mandates most medical AI is high risk, which means more algorithmic transparency, representative data sets, and continuous post-market surveillance. The problem with this is that over time, the amount of time it takes to get these products approved has ballooned from 6 months to 36 months, and now device makers are pulling out of Europe. China presents another option where state-controlled innovation and investment allows them to dictate what gets funded, when, and how. The challenge for this, when considering global health, is the limited transparency that we have to evaluate how well those products can be used outside of their country. One of the issues that we have is specialty concentration of these products. About 75% of approved AI devices are in radiology. Why? The data sets are easier. They're standardized, we have archived records, and they're abundantly labeled. We have clear performance metrics for radiology, which is wonderful. But the problem is that most of these devices are now succeeded in a field that we are close to solving, but most of the fields that we need these products for, primary care, infectious disease, metabolic health, are still lacking. And most critically, we've demonstrated that this isn't a trade-off between innovation and safety. It's an issue of trading off algorithmic bias with access to care. These markets are fragmented because the governments aren't talking to each other and the data isn't transferred between borders. So here's how we can build collaboration and accountability. First, we need to look at the evidence standards for these devices. If only 2% of cleared devices have prospective trials, we need to bump that up to at the very least 25%. We need to require real-world evidence within a year of FDA authorization, and we have the policy tools to make this happen. Drugs and devices today undergo coverage with evidence development. There's no reason we couldn't do this for AI products. Second, we need to look at equity. With over 99% of trials that are published missing socioeconomic data, we need to cap both our performance gaps between different ethnic groups, as well as whether or not Medicare and Medicaid decide to cover these products based on whether they meet current standards of health equity. Third, we need to look at continuous improvement. One concern that device makers have very reasonably is that once they have an authorized product, there's a lot of paperwork and a lot of further evidence generation that goes into creating an update. So the potential of these products is often limited by static regulatory standards that prevent us from allowing them to update in real time, preventing continuous evidence, and having the regulatory capacity at FDA and regulatory bodies around the world to continuously evaluate them. Finally, we need to harmonize standards across countries. We can't have products that work well in the United States but fail in Europe or Kenya or Taiwan. We need products that work across diverse populations with diverse data sets, which requires both access to these products early for patients, as well as the clinical and regulatory ability to evaluate them before they expand to too many people. And I propose we learn from history. In 2009, we passed the HITECH Act, which authorized about $30 billion to accelerate EHR adoption. Now, that had its problems, but it was largely successful in its goal. We moved from about 4% of hospitals that adopted EHRs before the act was passed in 2008 to 97% 7 years later. This came with challenges like issues with interoperability, difficulty with documentation, as well as alert fatigue. But we were able to understand the challenges that we needed to address in order to adopt EHRs globally. I propose, instead of giving incentives to adopt AI, we don't need that, the market will do it. We need incentives for AI evaluation in our hospitals. It's one thing for UCSF, which gets 100 pitches of these products each month, to look at those products. It's another to build up the capacity, both technical, clinical, and regulatory, to evaluate those products within a period of 6 to 12 months before deciding to employ them across the medical center. And unless this mandate comes from a collaboration between clinical staff and policymakers, it won't happen. And so this would both establish new evidence standards, which means that more of these products would undergo prospective clinical testing, as well as equity by design, meaning coverage is dependent on proper equitable standards for these devices, as well as the ability of our products to work both in San Francisco, but also around the world. And that's the road ahead. Thank you.
Thank you so much, Dr. Patel. Do we have time for a quick round of questions? Okay, very quick. All right. I am trying not to stay in the way of you all in lunch, but one quick round of questions for each of you. We heard from our last panelists, actually a very targeted message to ESIs to not be discouraged and to sort of stay in the game. So I wanted to ask each of you, how do you not only not be discouraged, but what excites you about your research and moving forward? Let's start with you, Dr. Chu.
Oh, sure, thank you. That's an exciting question, and I think what has been exciting to me is that amidst all the sort of craziness of the past year, like the fact that we're still able to form new partnerships, that our private sector partners are still working, they're still trying to find solutions to these problems because these problems haven't gone away just because our funding has. I think that's really exciting, and I'm still starting a lot of new collaborations with new partners, new technologies, and across behavior change, because as a health economist, I can work across multiple disease areas. So the ability to work with a lot of different and new partners is very exciting to me.
Yeah, I completely agree. Don't waste a crisis. This is, when there's a crisis, everybody says yes, especially here at UCSF. So like, if you want to do something, like everybody's like, do it, like, especially in a crisis. So it's a great moment for kind of enacting real, change. And I think, the research right now is never been more exciting. And so I cannot, just like, I focus on that and I just push forward in that. And that's just like, to me, sets me on fire. And so, and the other thing is I started my career, my faculty appointment started in February 2020, and I was pregnant with my first son, and I wrote a career award with a newborn baby and a shutdown, and without any family around. And so I think that time was very formative, and now we're in a different type of crisis, and now we have a new opportunity to really pave our way. So,
really, just to echo, these amazing points, is just being at this event. I mean, it's just been fun to see, your people. These are everyone that shares similar values and ideas, and that is so motivating. And even within your field, for me to be engaged with others that want to make this large impact, and across disciplines. I mean, I think that's another wonderful thing at UCSF, is to go to individuals that might come at it from a completely different angle, and to get excited and see that spark come and to create something new is really exciting, and I think what motivates me and many of us here.
I think a quote I hear often is that you are the average time with, and I could not feel luckier to be here at UCSF, where I'm constantly around a group of 5, 10, 500 people that are doing incredible work and keeping me both inspired and motivated to move forward. I'm relatively new faculty, and part of the reason that I decided to stay on after my training is that I could not imagine a place that's this inspiring and keeps me excited about my current work as well as the potential ahead, and I hope you all feel the same way.
Thank you very much, panelists, speakers. Thank you to my cabinet colleagues, the deans, for nominating these incredible scientists. And in general, I'm looking around the room and seeing our cabinet. The importance of political will is also local. The importance, the value of institutions' leadership, commitment to global health is very manifest in the audience. We're going to break for lunch, and after that, we have a very nice event for you where we will have Emmy Award-winning Kamau Bell in conversation with Dr. Mampele Rampele. And that will be, I'm sure, very interesting. So come back at 1:15 and enjoy your lunch and network. Thank you.